initiation of ARNI in early heart failure, which patient get hospitalized, don't hesitate to start ARNI if the potassium and creatinine is normal, if the blood pressure is more than 110. Titrate the dosages as soon as possible to get the recommended dosages by the end of 6 to 8 weeks. And that is what gives the best possible benefit. And that is not just true for the ARNI, for the other classes of drugs also. So with this, we go to the discussion, which is, I think, more important and more interesting part, for which we have Dr. Darshan Jhala, Colonel Garg, and Dr. Ashfaq Ahmed as an expert panelist, a very, very senior cardiologist, and they are bosses in their own field. And let us start the discussion. So I would start with Dr. Jhala. Dr. Jhala, sir, please tell us what are the current challenges of early initiation of ARNI in patients who have suffered a heart failure or who have just recently admitted to intensive care unit and don't just stabilized with the heart failure. So
yeah, so the challenges are more related to us rather than the patients.
Yes, sir.
So it is our resistance. We have a feeling that these people have just recovered from heart failure, so they will develop hypotension if I start something. Other concern is because they are all borderline renal, you can say dysfunction, because of an acute heart failure episode. So we are concerned about hyperkalemia. Third thing is we have just initiated or just taken them off diuretics. So again the concern of metabolic, metabolic parameters, etc. So I think it is our resistance which we have to overcome, because most of the time we are able to start ARNIs even as low as 100 milligrams. Potassium is not a concern. If you are able to think of starting either Enalan or ARB, then you should not hesitate in starting ARNIs. So I think we should overcome this fear. And once that hypotension is a big problem, it is not a problem. Take care of nitrate, stop them, remove the diuretic to a certain extent, and you will be able to start early ARNI therapy in most of the patients.
Yeah, thank you very much, sir. So basically, there are enough trials which have shown that early initiation is really beneficial, and the transition and pioneer, these are the landmark trials which have already taught us that by early initiation of ARNI, we can bring down the NT-proBNP significantly as early as first week. And we know that NT-proBNP reduction brings down the rehospitalization, brings down the mortality risk in our really sick patients. And as Dr. Jhala has already very clearly mentioned, that don't worry too much about the potassium, because ARNI are generally not very dangerous about the potassium, they are not as bad as MRAs. And accepting the blood pressure, in many of my patients, I accept BP between 90 to 100 systolic, as long as they do not have postural giddiness, as long as they do not have symptomatic giddiness while standing or while walking. So accepting little lower blood pressure to start with, and what we have observed that over the period, the blood pressure picks up. And this is one of the very important way of initiation, early initiation and early up-titration of the therapy, which is going to benefit our patients. So we ask the next question to Dr. Colonel Garg, that what intervention should we suggest for the initiation and optimization of ARNI in our clinical practice? So patient of heart failure stabilized, now patient unfortunately on ACE inhibitor and beta blockers and say diuretics. Now he comes to you with the ejection fraction of say 35%, still symptomatic, still has a little bit of leg swelling, still has low appetite, creatinine is hovering around 1.3 to 1.4, EGFR around 60, 70, diabetic patient. So what intervention you should suggest, sir?
Dr. Joshi, thanks for inviting me for this. And I am totally in consonance with what you have said and what Dr. Jhala has said. It is very important, and as you said, very rightly pointed out, that the BP generally builds up. Now, one of the major factors which I find, especially in heart failure, and we did write a paper on this when we were in Army Hospital, is the restriction to fluids, which is something which contributes to worsening of our kidney function, and also a lot of distress to the patient. Most of the patients, if they're passing normal urine, you will find that if they take normal fluids, it passes out. The treatment modality in such patients is, of course, diuretics and followed by DAPA, dapagliflozin or SGLT2 inhibitors, the ARNIs. Two other drugs which have come on the horizon are Finrinone, because that helps, is slightly, it's slightly BP neutral, as well as vericiguat. So when we come to this, and I think in a certain set of patients, digoxin does help. We cannot deny the role, and we are the old traditional doctors where we did use a lot of digoxin. So I would still not keep it out of our armamentarium, and a lot of my patients do continue to be both on ARNIs and on digoxin, and with good results. Thereafter, of course, after this, our treatment goes to device therapies, which are quite common and which we use quite efficiently, quite frequently. One, of course, being in case there's a left bundle branch block, then we go in for a CRT. Otherwise, an ICD is also not a bad option. And we have been doing a lot of patients with patients, especially who could not afford a patient, those patients with LBBB pacing. So these three, narrow QRS with LBB pacing, in fact, there are certain devices where even an ICD we place as for LBB pacing that lead, we go into the septal pacing, and a narrow QRS does help in these patients. What we find is ki, yes, the traditional viewpoint is that around 10% of the patients we are going to lose every year. But with good anti-failure therapy, and an important aspect that I insist and teach my students as well, that please, for the initial part, for the first 2 or 3 months, call them frequently, call them every 10 days, 15 days, 20 days, so that there's no drug default. Once they pass that Rubicon, once they cross that Rubicon of the initial therapy, a lot of these patients have a fairly good life and are generally in NYHA 1 to 2. In fact, a lot of patients drop out because they end up being in NYHA class 1 and 2. After some time, after 2 or 3 years, they suddenly resurface. And my being in the army, we used to get posted to different stations. So what used to happen was that they would find out my number and then ring me up after 3 years, 4 years. He said we were all fine as long as we were taking therapy, and then we suddenly stopped it. So patient compliance is again a very, very important factor.
Yes, excellent. So a patient and their family should be the part of the management of heart failure, and that is what
Absolutely. Absolutely.
2024 guidelines have clearly emphasized on. So if they are made to understand that by understanding the guideline-directed therapies, by understanding the fluid restriction, by understanding the salt restriction, and taking the medication right on time, and increasing the dosages as per requirement, are going to give them a hospital-free life and a longer life. I think they accept to it, and the best place to initiate therapy is shifting the patient from the ICU to the wards. So thank you very much, sir. And I would like to ask the next question to Dr. Ahmed. What would be your, see, we have 4 or 5 therapies for heart failure. So what should be the sequence of initiation of this heart failure therapy? Would you like to start with SGLT2? Would you like to start with the ARNI, or then MRAs or beta blockers? What should be the sequence in heart failure patients, especially in patients coming out of the ICU?
First of all, let me thank you, Dr. Joshi, and thanks, Devi Pharma, for giving me this opportunity. Coming to your question, sir, I think as per the data and as per the trials, recent trials, which considering there's a strong heart failure trial, which we have read, all of us have read, that it is, if the blood pressure permits, I think I'm going to start with all the 4 drugs in one go. The only question comes is when the patient is admitted with an acute decompensated heart failure, where we need to stabilize the patient first. And once the diuretic dose is reduced, then we consider what to start and how to begin with in the acute decompensated phase. Even in this phase, except beta blocker, we can gradually start with the lowest possible dose which we use once we come down with our diuretics. Coming to patients who are like already on ACE inhibitors, there are clear guidelines, the recent guidelines of the task force guidelines on how to start and which one to start. They have given that the patient who is already on ACE inhibitor, you can easily shift them to ARNI after a 36 hours washout period. And dosage also, they have mentioned that those who have been taking a higher dose of 10 milligram of equivalent enalapril, they can be directly started on 50 milligram twice daily. And if they're taking more, you can directly go to 100 twice daily. Regarding other drugs like MRAs, we just need to be cautious, as you said earlier, that considering hyperkalemia is one of the risk factors for initiating MRAs. So that is the only concern with MRAs. Beta blocker, again, when the patient is very congested and blood pressure is on the lower side, acute decompensated heart failure, we wait till the patient gets dry. And SGLT2 is quite safe. I think we can start it unless and until like there is a serious contraindications. EGFR also for SGLT2 is like up to 25-20 we can really start. So I would like to prefer to start all those drugs, 4 drugs in a low dose as early as possible if the condition permits, especially the blood pressure and hypotensive symptoms are the one which guide therapy for me.
Fantastic. So basically, patients who are dry, you can start all the 4 pillars straight away according to the blood pressure, titrate them as soon as possible. And what are the things we should observe on, say, when would you like to call these patients who are discharged from the hospital for the recent hospitalization?
I call them, I totally agree with Dr. Garg, what he said, like call them very frequently. I initially follow up in 1 week and then after 2 weeks. So once they come after 1 week, the 2 things happen. One is like we monitor them, and the patient also gets, once he gets the benefit of the drugs and he starts feeling better, then it is very easy to make them understand that these drugs are very necessary for it.
Yeah.
So adherence also improves in once we follow up very frequently in the first 2 to 3 months. So I usually prefer in the first week and then every 2 weeks for the next 1 month, and then after 4 weeks in the last one month. So like first 3 months, I take at least 4 to 5 follow-ups. First
Yes.
3 months
What
after
are the
this.
parameters to be followed on these follow-ups? What are the things to be followed?
Again, sir, starting from symptoms like whether they are having any hypotensive symptoms and all, any side effects with these drugs. That is the first thing the patients complain. And regarding the blood reports, I do follow with the electrolytes and the creatinine, also sugar, whether they are under control or not. And coming to the parameters of like echocardiographic parameters, I do repeat it in 6 weeks and then after again at 3 months. Surprisingly, I have seen a lot of improvement with ARNI group. Once we have started ARNI, I've been using it for the last 8 years. Everyone has been using it from 2015-16. So these are the things which we consider, and patients' overall symptoms improvement. These are the things we look at.
Yes. So
One of the things, Dr. Joshi, which I find is the BP part.
yes.
Now, if we start the mineralocorticoids in a low dose, like we generally start off with 12.5,
Yeah.
and then up titrate, because if you look at it, it's generally been recommended for resistant hypertension. And the fall with aldactone or eplerenone too, I don't like eplerenone very much. I like aldactone. I still like aldactone more than eplerenone. What we find is that we can maintain their BP at a good this thing. Yes, in case they are hypertensive and they have higher BP, then you up titrate to 25 or 50 milligrams of aldactone. But otherwise, we can generally manage with the 12.5 milligram dosage. And that gives excellent results because the patients are neither hypokalemic, neither are they hypokalemic. In fact, in my practice, we put in a lot of devices and a lot of this thing. Let me tell you, sir, very few of them, very rarely, maybe if I've got 100 devices under my follow-up, maybe just once in a while, maybe in a year or so, we would get one patient with a ventricular storm with dyselectrolytemia. Otherwise, most of the time, we don't even require to follow up on the electrolytes.
Thank you, sir. So talking
Yeah.
about the devices, may I ask one question to Dr. Jhala?
Yeah.
You're online, yeah. So, have you noticed that there is a decreased requirement of devices in patients who are already on ARNI as compared to those who were on ACE inhibitor or ARBs? So, have you seen the change?
Yes, as an electrophysiologist, I'm sorry to say that my device numbers have gone down after the army have come in. I don't know, but I mean during the main paradigm.
Maybe because they're surviving.
Yes, yes. So I think everybody must have experience in our clinical practice. Patients coming with heart failure of 20%, hardly anything. We can't eat or drink anything. And now with the ARNI and everything, patients got good appetite, LV function has improved. And initially we thought of, this patient is going to require CRTD. Now the patient doesn't require any devices. This is a common experience among all of us. So these are such a powerful and important medication that really reduce the risk of heart failure devices. So I think we should make all the efforts to initiate them and then increase it to the maximum tolerable dose. So the next question to Dr. Jhala sir, how do we diagnose heart failure with preserved ejection fraction? Very, very important diagnostic dilemma in all of our physicians.
See, basically, we have to pay good attention to clinical findings. You have to give importance to symptoms. I understand symptoms of heart failure could be non-specific. They could be confused with asthma, COPD, a lot of things. But if you look at the patient profile, for example, he is a 60-year-old who was never asthmatic. He has got hypertension and he has started complaining of breathlessness. And the echo shows that the ejection fraction is 55%. This is a person who's the right person for the diagnosis of HFpEF. Now, the next step would be, of course, to do a physical examination. And if they are not on diuretics, then generally there is some elevation of the jugular venous pressure, and there is a fourth heart sound which is generally heard. So these are hardcore clinical findings. Apart from that, you can always rely on NT-proBNP, not too much, because in HFpEF, NT-proBNP is not all that elevated. It may even be normal. But if you look at the echo parameters properly, there will be an indication the EE prime will be elevated, the E velocity will be increased, the LA will be enlarged. Keeping in mind the company of hypertension and diabetes, it should be easy to diagnose heart failure with preserved ejection fraction. Of course, we have these scores, HFpEF, etc. Scores, but I think essentially they come to the same thing. That you look at the patient profile, fit the NT-proBNP echo findings, and then come to the conclusion. Provided there is a good symptomatic background that the patient has symptoms. Because you can easily confuse it with a normal person. Normal person also has no symptoms.
Your
So Dr. Veeramani and Dr. Hitesh sir is also there. Sir is paused.
Okay. So basically, heart failure with preserved ejection fraction. To diagnose that, as Dr. Jhala has said, you have to have good clinical suspicion, and then think in that way, and then thorough clinical examination, echocardiography parameters, and if needed, NT-proBNP levels. Sir is back, so you can continue, sir. We were paused in between. Yeah. Can you continue, Dr. Jhala? I can see you.
Can't hear, sir. Dr. Jhala, sir? No. Dr. Veeramani, sir, is there, sir. Can you take his? Yes.
So,
sir, as rightly told by our senior doctor, that the echo parameters in the form of E velocity and all that will be very much useful in day-to-day practice. How to assess whether the patient needs, the patient is in a state of diastolic heart failure along with hypertension, whether we have to start with the ARNI. The echo parameters, apart from NT-proBNP, is very much useful. The echo parameters is a very correctly told that is in day-to-day practice we can very much use the echo parameters.
Yes, so the landmark trial on heart failure with preserved ejection fraction, the Paragon trial, which have maybe slightly missed with the clinical significance or statistical significance by few patients, but it has given us a good message about some kind of patients. So what we know that the HepPEF is a disease of elderly and disease of the comorbidities. And if we look at the patients who have been benefited in HepPEF, because with the ARNI are those who are elderly and female patients. So these are the two subcategories which they have observed that there was a significant benefit if it comes to reduction in NT-proBNP or reduction in heart failure hospitalization. The mortality benefit was not significant at all, but heart failure rehospitalization benefit was certainly there. So patients, elderly and female patients, definitely benefited much more than the other population in this Paragon sub-study. That is also one of the message. Dr. Veeramani, can you guide on how do you treat the patients of heart failure, especially in female with hypertension? So patient is already on beta blocker, patient is already on ACE inhibitor, patient is already on diuretics, patient is already on MRAs. And now patient comes with systolic blood pressure of 170/90 and patient complains of dyspnea on exertion on climbing stairs. So how would you assess such patient?
Yeah. In that case, we can use the echo parameters to assess whether the diastolic heart failure situation is there. In that case, we can change the AC inhibitor ARB to ARNI with we can variable change. That will be definitely helpful. Previously, we have talked about the what is the use in hypertension as per the 2023 European Society of Hypertension guidelines. In place of AC or ARB, we can use the ARNI to control the hypertension as well as the heart failure for the in presence of the hypertension.
Okay, so there is a very big, beautiful concept mentioned as a ventriculovascular coupling, which occurred in heart failure with preserved ejection fraction. It is not just the diastolic dysfunction. There is a decoupling between ventricle and vasculature, and which is being taken care by ARNI, and that is why where the role of ARNI comes into the picture. And at present, maybe we are 2A indication for HepPEF, but probably with the bigger data and more patients getting into the bigger trials, we'll have the higher indications for ARNI. So with this, I would like to ask you how important it is for us to have the original drug as compared to the other formulations which are there in market. So every medical company nowadays has ARNI on their own. So they have A, B, C, D. How important it is to have the proper co-crystal formulation to give the benefit. So anybody can take the question.
Dr. Hitesh Shah, Dr. anyone, sir, Dr. Jhala, sir, Dr. Garg, Dr. Veeramani. Yeah, Hitesh Shah, sir, please.
Yeah, I think I had included 3 or 4 slides regarding that. I think there is no, we cannot say that some brand is inferior, some brand is superior. So there has to be some norms. Innovator brands, definitely we can say that it's good test profile and it's bioequivalent regarding that crystallization and that molar ratio, everything. Because that's not a, as being a medical professional, that's not our domain to know that. So there has to be some body which needs to regulate this in terms of bioequivalence and availability of the drug.
But
We
at
being
least
a medical
we have the
professional
data
can
with the
derive the
innovator
conclusion
molecule.
from our experience only.
Right.
Hello?
But at least we have the strong data
Yeah,
from
but
the innovator molecule.
Innovator molecule is now coming at almost similar cost as the generic molecule. So,
yes,
if given choice, then we should prefer the innovators.
Yes. So with that, we come to closing of this. 2024, we have seen a lot of changes in heart failure management as compared to last decade or so. There are excellent medications which have come with that can reduce the outcome like cardiac mortality and heart failure hospitalization. But we have faced the problem of underutilization of the medication, especially GDMT medication. there is always resistance and fear in the mind when to start, whether to start these potent drugs in ICU setting or in hospital. And we have got a clear answer now that the earlier we start this medication, as soon as the patient hemodynamically stabilized, and up titration of this medication to the maximum tolerable dose, that should really reduce the patients from coming back to the hospital or improving their and that also improves the mortality in these patients. Again, patient communication is one of the very important thing, and patient and their family should be the part of the management, and they should be made to understand that such medicines are they going to help their patient by reducing the rehospitalization rate and improving the overall survival. Again, heart failure with preserved ejection fraction is a difficult ball game altogether. We need to have a higher index of suspicion, and we have to be aggressive about controlling their risk factors, as well as studying their patient, like patient who have sleep apnea and coming back with breathlessness. Sleep studies should be done, and then patient should be kept on the guideline directed medical therapy, as we know that SGLT2 inhibitor, ARNI, MRAs are the cornerstone in patient with HFpEF, in addition to their modification of the risk factors like controlling diabetes and hypertension. Early identification is the key in patients with HFpEF, and we can prevent the progression of HFpEF into terminal heart failure. And for that, the overall overview about management of the patient should be patient-centric, and it should be focused on reducing the rehospitalization and improving the overall survival of this patient.